Tamilarasi, Senior Consultant Enterprise Surgery Foundation, to present her talk on maintaining a logbook with purpose and meaning.
Good morning, one and all. I'll be talking about maintaining a logbook. The quality of clinical training depends upon two main factors. One is the number of cases the trainee is getting, and second, the clinical expertise of a trainer. And we know that there is a no standard set guidelines about the number of cases a resident would operate, and also the teaching experience of the trainer varies. So there is a great variation in the learning experience of a resident. So logbooks have been introduced to ensure consistent quality and standards in surgical training. I'll be sharing my experience how I introduced a logbook for training at the AIOC Foundation. What are they? They are nothing but a set of learning objectives for the specified education time period. So once the resident comes to know about this, they will know what is expected from them. So this imparts a right positive attitude and better engages them in the learning process. Overall, it improves the structure of the training. Though logbooks are perceived useful, few of them, like here as shown the student response, around 20 to 29% perceive them as not useful. When it can flop if the structure of the logbook is not clear, and when the work becomes more of a data entry, it becomes boring and less engaging. So with constant monitoring and structuring the logbook clearly, it can be made really useful. So this was the existing logbook which was there for a BNP residents. Here, they enter the individual patient details about the operative notes, the complications, and the post-op visual acuity. Overall, it looks good, but what are the downsides? Here, there is a repetitive writing of the same surgical notes again and again, and unless it is not, it is monitored, we are going to fill only during the exam completion. And so it becomes a boring and less engaging. Though it provides details of the complication and visual outcome for individual cases, it does not provide any platform to analyze the visual outcomes. And hence, I am not able to measure the performance of a resident. So I structured a logbook which was made very simple to help in the training process. So the contents of the logbook should be constructively aligned with the curriculum. What I mean is the learning objectives of the logbook should be integrated with the curriculum what we have. Once this happens, the students take their own responsibility of their learning process. So when I structured, I kept it very clear to mirror the activities, whatever it is happening in the wet lab and inside the OR. So at the beginning, I will introduce the logbook and understand the resident, the usefulness of it and how to enter it. And also encourage them to submit it weekly so that I'm going to give a feedback. All this helps. When I see this logbook, I know how is their learning progress, and also it gives the overview of the requirements of the clinical training. So to tell that it should be a basic, it should be simple, and also it has to be comprehensive. So our curriculum of surgical training, it starts with small incision cataract surgery at the 4th month. Once the resident picks up the comprehensive eye examination skill, and in final year we teach them phacoemulsification. So in the beginning of their wet lab, they attend a series of lectures and write modules, which ranges from simple pre-op evaluation to the IOL calculation, and they document it. And they spend a considerable amount of time in the wet lab, 2 to 4 hours in a week. All these things are supervised. Where they learn, this is the same thing which has been they are practicing in both. So it was just to show how they are practicing their spiral tunnel and suturing technique in a roadside. So here they learn to orient the use of the surgical instruments, operating microscope, and they learn the hand-eye coordination. And also for phacoemulsification, they learn to perform the nucleotomy technique in the practice eye model. Also, we take the nucleus extracted from small incision cataract surgery, freeze it, and also place it to better understanding chopping technique. All these things are monitored and supervised by the senior residents, and I also give them timely feedback. And to ensure this, I also tell them even after they enter the OR, if they want to refine a specific surgical skill, they should never hesitate to go back to the wet lab and learn the same. All this exercise tells them that they have to spend a considerable amount of time and effort in the wet lab before entering the OR. and also ensures the fact that the patient and their outcomes always comes before their training. After 4 to 6 weeks of the commencement of the wet lab training, I sit with them one-to-one and ask them regarding the various steps of cataract surgery. This includes both for SICS and phacoemulsification. So by this end of this, I will be able to know whether they have understood the various surgical steps and what are the weakness and the areas they need to improve. I leave a gap of 4 weeks and reassess them and ensure that they understand the basics of all the surgical steps. All these acts as an evidence that we have taught them that the evidence learning has taken place, and when a resident starts his or first case depends upon the surgical aptitude of the resident. I may construct judgment regarding the surgeon's training. Once they enter the OR, they enter all these things, which is the stepwise analysis of the cases, visual outcome monitoring, the complication rate, and also about the surgical audit. So this is a stepwise analysis of the case. So for each of the steps, they enter whether the step is done by them or with help or done by a senior. So once they do at least some 30 to 40 cases, this helps them to analyze their learning curve. Previously, they were not able to do, and now they are able to do all these steps by the end of 30 to 40 cases. So they are comparing themselves with themselves and not with their peers, and this triggers them to learn better. They also bookmark with the EMR that whenever the patient comes for the post-op follow-up, they will be called and they see the post-op and they document the post-op visual outcome. By this, they understand the surgically induced astigmatism and the amount of trauma the surgery has induced, and also learn about the error in biometry. Regarding complication, whenever complication happens, I discuss with them what is the best part of the surgery and what could be done better. And I always try to keep the feedback as constructive as possible. And I encourage all my residents to record and review the video. For each of the steps, they will know what is the best part of the surgery and what are the areas that need to be improved. And I also encourage them to assess the time taken for each of the steps. And for example, if a resident tells me immediately after surgery that they attempted a hydroprolapse but the nucleus didn't prolapse, when I ask why, they won't be able to tell me the reason. But when I sit and discuss with them, they will understand. First, they should look into the size of the rexus if the nucleus is not prolapsing, and second, the placement of the cannula and the technique of injection, whether it is correct or not. So once we do the surgical audit, it will help them to analyze the concept and encourage them to think critically and act according to the situation. So all this exercise which has been discussed till now, that is seeing the patient post-op, entering the visual outcome and doing the surgical audit, all these things they need to carry it over into the future professional career. So getting this habit early is really good. So as a trainer, we know that the learning curve of cataract surgery is really steep, and we need to provide the space and time to give them a constructive feedback so that they can become a surgeon of highest type. So to conclude, the logbook should be constructively aligned with the curriculum, and this helps in surgical training really. Thank you.
Thank you. Along with the logbooks, do you encourage recording and do you work with them on that?
Yeah, surgical video recording I encourage, ask them to review it personally themselves and along with the seniors, and if they have any doubts, they will bring it to me also. And if they have a complication, I do sit with them and watch it.
Is it routinely recorded and taken out occasionally, or
Routinely it is recorded, but there are two operating tables in a OR. Usually the recording system is there on the first table. So sometimes it may not have.
Yeah, because as you mentioned, you can go back and discuss. It would probably be more advantageous to discuss the areas where they were finding it a bit of a challenge to go back and discuss. That would be very good. And at our place, we also have these presentations of these recordings. Just randomly, just one recording is lifted out by the senior resident or supervisor, and they are discussed in the entire unit or entire group of residents of that particular group. So presented and discussed. So again, it's not judgmental discussions. It's like everybody is getting an opportunity. So and they are done with their senior residents or their supervisor faculty, junior faculty, so that they don't feel kind of threatened or something like that. But yeah, as you mentioned, it's important to discuss where the challenge occurred during the course of the surgery, and everybody can learn from others' mistakes also. So it is, but wonderful, excellently shown how to document, because now it's becoming increasingly important for them when they go onwards to have a proper documentation of what we have assisted, what we have personally done. So, thank you.
Beautiful talk, Tamilarasi, as usual. But just three important things are very, very vital, I would say. You mentioned logbook is a must. Number one. Number two, all the cases, the resident cases are recorded and they have to be reviewed. Recorded and reviewed. Not only recording, they put it in the dustbin. So it's recorded and reviewed. Third is the surgical auditing. That also you mentioned beautifully. So these are three things I think very, very important for the surgical training program.